Okay, let's unpack this. Welcome, deep divers. Today we're embarking on really a crucial journey into the landscape of mental health.
Yeah.
You've sent us just a wealth of incredibly rich sources. I mean, everything from foundational definitions of, what mental well-being truly means,
Mhm.
to the fascinating intricacies of our brain's chemistry, and even the vital principles guiding how care is delivered.
And what's truly fascinating here, I think, is that this material offers such a comprehensive lens. It helps us understand not just what mental health and illness are,
Right.
but also the why behind them, and importantly, how support and care are structured. So our mission today is really to distill these sources,
Mm.
help you navigate the complexities, spot those critical connections, and hopefully walk away feeling genuinely well-informed, ready to see the world of mental health with, perhaps, some new clarity.
Yeah, think of this deep dive as your ultimate shortcut to understanding the human mind, its vulnerabilities, its incredible resilience, and the intricate ways we try to support it. We'll be uncovering some surprising insights and essential distinctions that are, frankly, far more valuable than just a quick headline. Ready?
Let's do it.
Let's dive in. So, to kick things off, let's get right to the heart of it. What exactly is mental health? Our sources, they paint a picture of it as um, a dynamic state, right? Not some fixed point.
That's a great way to put it, dynamic.
Yeah.
It's where you're able to realize your own abilities, cope with the normal stresses of life,
The everyday stuff.
the everyday stuff, yeah. Be productive, contribute meaningfully to your community. It sounds simple, but it's actually quite profound.
It really is. And the contrast then is mental illness.
Right. Which is a diagnosable disorder. It involves significant disturbances in how someone thinks, regulates emotions, or behaves. And this impairment, it affects their daily functioning.
Okay.
But what's absolutely crucial to grasp, and something many people misunderstand, is that it's not an either-or thing.
Ah, yes, the continuum.
Exactly. Mental health exists on a continuum, a
Yep.
spectrum, and you can move along it.
Yeah.
One day you might be thriving, another day really struggling, depending on life challenges.
Okay, that leads perfectly into, I think, one of the most powerful aha moments for many people, something our sources really illuminate called the diathesis stress model.
Big one.
Yeah. This model, it completely reshapes how we think about the causes of psychiatric disorders. It suggests they're a combination of two things: a genetic or biological vulnerability, the diathesis,
Right.
and environmental stress.
Exactly. And this model, it just beautifully illustrates that when it comes to psychological well-being, it really is nature and nurture working together.
Okay.
So imagine two people. One might have a high diathesis, a strong genetic predisposition, let's say,
Mm-hmm.
and they might develop a disorder with even relatively mild life stress.
Mm-hmm.
The other might have a low diathesis and need severe, prolonged stress to develop similar symptoms.
Mm-hmm.
But here's the hopeful part.
Mm-hmm.
Strong support systems, healthy coping skills, these can actually act as powerful protective factors. They can prevent a disorder even in people with those genetic predispositions.
So it's not just what you're born with or what happens to you, but also how you're supported, the tools you
Yeah.
develop.
Precisely. Our sources highlight these protective factors, things like strong social support, access to education, employment, healthy coping mechanisms, reliable healthcare.
Right. And central to all this is resilience, isn't it? That incredible ability to recover from adversity, to bounce back.
Absolutely. Often built right through those protective factors.
Now, let's shift gears a bit. From these overarching models to the incredibly intricate world inside our heads. The brain's language, its chemistry. When we talk mental health, we often talk about neurotransmitters.
Chemical messenger.
Yeah. What are these things, and what's maybe one key thing listeners should really grasp about how they shape our mood and cognition?
That's a great question. Think of neurotransmitters as tiny chemical couriers. They're constantly sending messages between brain cells. They influence, well, everything, how we move, learn, our mood, sleep, appetite.
Wow.
The key insight, I think, isn't to memorize every single one, but to understand that balance is crucial.
Balance.
For instance, dopamine, vital for motivation, reward. An imbalance can contribute to psychosis or, on the flip side, depression.
Yeah.
Serotonin profoundly impacts mood, sleep, appetite. Imbalances there are often seen in depression and anxiety. So the central takeaway is that when these chemical systems are out of whack,
Yeah,
it can significantly impact mental well-being.
that makes so much sense, that delicate balance, which brings us naturally to medications because they directly interact with these systems.
They do.
And here's where a truly vital insight from our sources comes in, especially if you know someone starting antidepressant therapy. Especially adolescents and young adults may experience increased suicidal thoughts or behaviors during the very first weeks, before their mood even begins to improve. That's huge.
It is huge. And that's not just, a minor side effect note. It's a critical safety warning. It really reshapes how we approach that initial treatment phase.
Right.
It just emphasizes the absolute necessity of close monitoring during that early period. And this principle, this close monitoring, it extends to other powerful medications too. Take lithium.
Ah, yeah, for bipolar disorder, often.
Often, yes, it's a common mood stabilizer, but it has a very narrow therapeutic window, meaning the difference between a dose that works and a dose that's toxic is really small.
Okay, so even a slight misstep could have serious consequences. What are some of those warning signs someone should be aware of with lithium?
Precisely. With lithium, early signs of toxicity might be things like tremors, confusion, maybe diarrhea.
Okay.
In more severe cases, it can lead to seizures or even kidney damage. That's why regular blood tests are absolutely mandatory. You have to ensure levels stay within that safe, effective range.
Wow.
And another critical warning sign to be aware of, less common, but life-threatening, is serotonin syndrome.
Right, you mentioned serotonin earlier.
Exactly.
Yeah.
This happens if serotonin levels become excessively high, often from combining certain drugs that boost serotonin, like maybe SSRIs, with MAOIs.
So mixing meds can be dangerous here. What does it look like?
The symptoms are pretty severe. Agitation, confusion, rapid heart rate, dilated pupils, muscle rigidity, and dangerously high body temperature hyperthermia. It's a true medical emergency.
That just underscores the importance of, a detailed medication history and really careful prescribing.
Absolutely.
And when we talk about some of the older antipsychotic medications, the first generation ones, our sources highlight some potential side effects that are, profoundly impactful.
They do. While these older meds, sometimes called typical antipsychotics, can be incredibly effective, especially for positive symptoms like hallucinations.
Right.
They sometimes cause extrapyramidal symptoms or EPS. These are involuntary movements or muscle issues, things like dystonia, prolonged muscle contractions, or akathisia. This intense inner restlessness makes it hard to sit still. And perhaps most significantly, there's tardive dyskinesia, TD.
TD, I've heard of that. It can be irreversible.
It can be, yes. And it involves repetitive involuntary movements, often of the face, lip smacking, grimacing, tongue thrusting, rapid blinking. It really highlights the delicate balance providers have to strike between symptom control and managing these challenging side effects.
Absolutely. And there are other major warnings too, right? Like with clozapine?
Yes, clozapine, an atypical antipsychotic, carries a risk of agranulocytosis. That's a severe drop in white blood cells, which fight infection. Requires very strict routine blood monitoring.
Okay. And neuroleptic malignant syndrome.
NMS. Rare, but another potentially fatal reaction, usually to antipsychotics. High fever, extreme muscle rigidity, autonomic dysfunction like unstable blood pressure and heart rate, and altered mental status, another medical emergency.
Wow. So just to quickly recap some key med classes for listeners, maybe one standout note, SSRIs.
Like Prozac, Zoloft. That black box warning we discussed about increased suicide risk in young adults early in treatment.
Okay. TCAs. Amitriptyline.
Tricyclics. Older antidepressants. Big concerns are cardiac toxicity and fatal overdose risk, generally avoided in older adults.
MAOIs. Nordil.
Monoamine oxidase inhibitors. Very effective, but require strict dietary precautions. Avoiding tyramine-rich foods like aged cheeses, cured meats.
Right, the cheese effect.
Exactly. Can cause a hypertensive crisis, dangerously high blood pressure.
Benzodiazepines. Ativan, Xanax.
Used for anxiety, sometimes sleep. Major risks are dependence, tolerance developing, and sedation. Not ideal for long-term use.
And antipsychotics, we touched on FGAs, the older ones. SGAs, the newer ones.
Right. FGAs like Haldol target positive symptoms but have that higher EPS-PD risk. SGAs like risperidone or clozapine often help with both positive and negative symptoms but come with their own set of risks, often metabolic side effects like weight gain, diabetes risk.
So clearly medications are powerful tools, but gosh, they come with significant considerations. Which brings us to a broader question. How is mental health care actually delivered? What are the different environments? Our sources outline a spectrum.
It really is a spectrum, yeah. From the least restrictive to the most intensive. On one end, You have outpatient care.
Like therapy sessions, doctor visits.
Exactly. Then there are more structured options, like partial hospitalization programs, intensive daytime treatment. But you go home at night.
Okay.
And then at the most intensive end, you have inpatient care, usually in a hospital setting, for acute situations where someone might be a danger to themselves or others.
Right, and sometimes that involves involuntary commitment. We saw a specific note about Georgia's 72-hour hold.
Yes, most places have legal mechanisms for short-term involuntary holds for assessment and stabilization if someone meets specific criteria for being in imminent danger. The exact time frames and criteria vary by location, like that 72-hour example in Georgia.
And within these settings, especially inpatient, creating the right environment is critical. This is where something called milieu therapy comes in. What are the core components? What makes an environment therapeutic?
Milieu therapy is all about deliberately crafting a safe, structured, and supportive environment. It emphasizes patient involvement in their own care, group interaction, and crucially, validating their experiences. The idea is that the environment itself becomes part of the healing process.
So it's more than just a place to stay.
Much more. It involves safety protocols, predictable routines, opportunities for social learning, support from staff and peers. It's quite holistic. And underpinning all of this are fundamental patient rights.
Yes, absolutely vital. Like,
The right to informed consent, understanding treatment before agreeing. The right to refuse medication, with certain exceptions and emergencies. The right to privacy and confidentiality, humane care, and importantly, the right to receive care in the least restrictive environment possible.
and speaking of least restrictive, our sources put a really strong emphasis on the regulations around seclusion and restraints. This sounds like a truly last resort measure.
Oh, absolutely. It's used only to prevent imminent harm when less restrictive methods have failed.
It's heavily regulated. What are some of the critical safety aspects here? Things like time limits.
Yes, very strictly regulated. It always requires a medical doctor's order, renewed frequently. It's always time limited, for example. The sources mentioned a typical limit of 4 hours for adults, 2 hours for adolescents age 9-17, and just 1 hour for children under 9. And it demands constant observation and regular checks for safety and comfort. It highlights the immense responsibility involved.
Absolutely. Now, beyond the formal structure and rules, something that comes up again and again is the power of human connection in a therapeutic relationship. What makes these relationships so impactful?
It really comes down to core elements like trust, empathy, really trying to understand the other person's world, genuineness, being authentic, and something Carl Rogers called unconditional positive regard.
Unconditional positive regard. What does that mean in practice?
It means accepting and respecting the person as they are, regardless of what they say or do. It's seeing their inherent worth, even when their behaviors might be difficult or challenging. It creates a safe space for them to explore and heal.
And these relationships, they aren't just accidental, right? They follow intentional phases. Our sources highlight Peplaw's phases of a therapeutic relationship. Can you maybe walk us through them briefly, just to show that intentionality?
Sure. Hildegard Peplaw's model is foundational. It starts with the pre-orientation phase. That's the nurse or therapist preparing, gathering information, examining their own feelings before meeting the patient.
Okay, homework first.
Homework first, yeah. Then the orientation phase. This is where the relationship starts. You introduce yourselves, build rapport, clarify roles, discuss confidentiality, and begin to identify the patient's problems and goals. Trust starts here.
Right. Then the real work begins.
Exactly. That's the working phase. This is usually the longest phase. Problems are explored more deeply, coping skills are developed, insights are gained, behaviors might change. There can be testing of boundaries here, too.
Makes sense. And finally,
The termination phase. This is a planned ending. It's not just stopping. You review the progress made, discuss feelings about ending the relationship, and plan for continued support or relapse prevention. It provides closure.
that makes so much sense, seeing it as a journey with clear stages. And during that journey, especially in the working phase, there are often dynamics that need careful management, like transference and countertransference. What are those?
Oh, yes. These are critical awareness points for any healthcare professional. Transference is when a patient unconsciously redirects feelings or attitudes from a past significant relationship, like with a parent, onto the therapist or nurse.
So they might react to the nurse as if they were their mother, for example.
Exactly. Could be positive or negative feelings. Countertransference is the reverse, when the professional projects their own unresolved feelings, attitudes, or experiences onto the patient.
Ah, okay. So the professional needs self-awareness there.
Huge self-awareness. Recognizing these helps maintain professional boundaries and ensures the focus stays squarely on the patient's needs, not the professional's issues. And when it comes to the actual communication within that relationship, effective techniques are just foundational.
Like what? What works?
Things like active listening, really concentrating, understanding, responding, remembering what's said, using silence strategically, allowing the patient time to think and process, paraphrasing to check understanding, reflection to echo their feelings, offering self, just being present, broad openings like, what's on your mind?
So really hearing and understanding, not just waiting to speak or jump in with solutions. What should we absolutely avoid in these sensitive situations?
Crucially, avoid giving unsolicited advice. Don't offer false reassurance saying everything will be okay can minimize their real pain. Avoid changing the subject inappropriately. Definitely avoid judgmental comments or tones. And be very careful with asking why questions.
Why questions? Why avoid those?
They can easily sound accusatory or judgmental, like, why did you do that?
Hmm.
It can put people on the defensive. It's often better to ask what or how questions. What happened then? Or how did that make you feel?
Mm.
The goal is always to create a safe space for expression, not to interrogate or fix immediately.
Okay, that's incredibly helpful. Now let's shift gears slightly and navigate some of life's common challenges, starting with something universal. Stress. It's so much more than just a feeling, isn't it? Our sources highlight two main types.
Yes, absolutely. There's eustress, which is actually positive stress.
Yeah.
It can motivate us, energize us, like the excitement before a big presentation or a wedding.
Okay, the good kind of butterfly.
Exactly. Then there's distress, which is the negative, harmful kind. This is the stress from chronic illness, job loss, relationship problems, the kind that wears you down.
Yeah. And the connection between mind and body here is profound. Hans Selye's model. Chronic stress has real physical consequences.
Absolutely. Selye's general adaptation syndrome showed how chronic stress taxes the body. Over time, it can lead to things like immunosuppression. You get sick, more easily digestive issues, cardiovascular problems, sleep disturbances, even autoimmune conditions, flare-ups. The mind-body connection is undeniable.
Wow. Okay. Another really common experience is anxiety. And like mental health itself, it exists on a spectrum. Our sources outline levels of anxiety.
Right. From mild anxiety, which can actually be helpful, it heightens awareness, helps you focus, prepares you for action.
Like before a test.
Exactly. Then moderate anxiety, where your perceptual field narrows a bit, you might miss some things. Severe anxiety, where your focus is significantly reduced, you might only focus on one detail. Learning is difficult. And then panic.
Panic level. What's that like?
At the panic level, the person is overwhelmed, unable to process what's happening, might feel like they're losing control or dying. Rational thought is really difficult. They can't function effectively.
And people develop ways to cope with anxiety, sometimes unconsciously defense mechanisms.
Yes, Anna Freud really detailed these. Things like denial, refusing to accept reality. Projection, attributing your own unacceptable feelings to someone else. Displacement, shifting feelings onto a safer target. These can be adaptive in the short term, but problematic if overused.
So when does anxiety become a disorder? Like generalized anxiety disorder, GAD? What's the key insight there?
With GAD, the key insight is the constant excessive worry about multiple everyday things. Health, finances, work, family. It's persistent, difficult to control, and significantly impacts daily life. It's not just worrying about a specific upcoming event, it's this free-floating, pervasive anxiety. People often describe feeling on edge, fatigued, having trouble concentrating because their mind is always racing.
That sounds exhausting. And panic disorder, different from just having a panic attack.
Yes, panic disorder involves recurrent, unexpected panic attacks, and then persistent worry about having more attacks or the consequences of them. The attacks themselves are sudden, intense episodes of fear, often with physical symptoms like a racing heart, shortness of breath, chest pain, dizziness, sometimes feeling like a heart attack.
Wow. And phobias, intense fear of something specific.
Exactly. An intense, irrational fear of a specific object or situation like spiders, heights, flying. The fear is way out of proportion to the actual danger, and the person goes to great lengths to avoid it.
Okay. OCD, obsessive compulsive disorder. That's the obsessions and compulsions loop.
Precisely. Obsessions are intrusive, unwanted thoughts, images, or urges that cause significant anxiety. Compulsions are repetitive behaviors or mental acts the person feels driven to perform, often to reduce the anxiety caused by the obsessions or prevent some feared event. It becomes a time-consuming, distressing loop.
And social anxiety disorder, more than just shyness.
Much more. It's an intense fear of being judged, negatively evaluated, or rejected in social or performance situations. People might dread meeting new people, speaking in public, even eating in front of others. The anticipation anxiety can be crippling.
From anxiety, let's delve into depression, understanding its depths. For assessment, our sources provide a really useful acronym, SIGCAPS. What does that stand for again? Why is it helpful?
SIGCAPS is a great mnemonic. It stands for sleep disturbances, insomnia or hypersomnia, decreased interest or pleasure, anhedonia, guilt or feelings of worthlessness, decreased energy, fatigue, decreased concentration or indecisiveness, changes in appetite, increase or decrease leading to weight changes, psychomotor changes, agitation or retardation, slowed movement, speech, and suicidal thoughts.
Okay.
It's helpful because it quickly covers the core diagnostic criteria for a major depressive episode, ensuring a comprehensive assessment.
And for severe depression, the kind that doesn't respond well to medication or therapy, electroconvulsive therapy, ECT, comes up.
Yes, ECT. It's often misunderstood, sometimes stigmatized because of historical portrayals. But the key insight is that modern ECT is a safe and highly effective treatment for severe treatment-resistant depression, severe mania, or catatonia.
But there are side effects, memory issues.
Yes, the main side effects are temporary confusion immediately after the procedure and some memory loss, particularly around the time of the treatments. Usually this improves, but it's a significant factor to consider and discuss with patients.
Okay. And then there's the roller coaster of mood, often associated with bipolar disorders. Our sources differentiate between types. Can you briefly explain the difference again between type I and type 2?
Sure. The main distinction lies in the severity of the up periods. Bipolar type I involves at least one true manic episode. Mania is a period of extremely elevated, expansive, or irritable mood, plus increased energy and activity lasting at least a week, causing significant impairment. They may or may not have major depressive episodes, though most do.
Okay, true mania. And type 2?
Bipolar type 2 involves at least one hypomanic episode and at least one major depressive episode. Hypomania is similar to mania, but less severe. It doesn't cause major impairment in functioning, doesn't require hospitalization, and doesn't have psychotic features. But the depressive episodes can be very severe and debilitating.
And cyclothymia?
Cyclothymia is sort of a milder, more chronic form. Numerous periods of hypomanic symptoms and periods of depressive symptoms for at least 2 years. But the symptoms don't meet the full criteria for a hypomanic or major depressive episode.
Got it. And a crucial symptom of mania itself, you mentioned pressured speech before. What are some others?
Besides pressured speech, key mania symptoms include decreased need for sleep, feeling rested after only a few hours, or none, increased distractibility, involvement in activities with high potential for painful consequences, spending sprees, risky investments, sexual indiscretions, grandiosity or inflated self-esteem, and flight of ideas, thoughts racing, jumping from one topic to another.
That paints a very clear picture. And you mentioned lithium earlier, still a key treatment.
Yes, lithium remains a gold standard mood stabilizer, especially for classic bipolar Y. But again, that narrow therapeutic window and toxicity risk, the tremors, confusion, GI upset, progressing to seizures, coma, require constant vigilance.
Are there other mood stabilizers? Any key warnings with those?
Oh yes, drugs like valproic acid, Depakote, carbamazepine, Tegretol, and lamotrigine, Lamictal, are also widely used. Lamotrigine has a specific serious warning, the risk of a severe, potentially life-threatening rash called Stevens-Johnson syndrome, especially if the dose is increased too quickly, requires slow titration.
Wow. Okay, finally in this section, let's look at schizophrenia and try to deconstruct some common perceptions. Our sources help us understand its core symptoms by categorizing them into positive and negative. Can you unpack that for us?
Yes, this is a really helpful way to think about it. The key insight, as you said, is that positive symptoms are things that are added to a person's experience, things that shouldn't be there but are.
Like hallucinations and delusions.
Exactly. Hallucinations, sensory experiences without external stimuli, most commonly auditory hearing voices, and delusions, fixed false beliefs despite evidence to the contrary, like paranoia or grandeur. Also disorganized thinking, which shows up as disorganized speech, jumping topics, incoherence. Disorganized or catatonic behavior too.
Okay, those are the added symptoms. What about negative symptoms?
Negative symptoms represent a deficit or lack of things that should normally be there. They often involve a reduction in normal functioning.
Okay,
like alogia, which is poverty of speech, reduced quantity or content. Avolition, a lack of motivation or ability to initiate and persist in goal-directed activities.
Yeah.
And hedonia, which we mentioned with depression too, a decreased ability to experience pleasure from positive things.
Right.
Also, sociality, a decrease in social interactions and interested relationships. And affective flattening or blunted affect, reduced expression of emotions via facial expression, eye contact, intonation.
And one more you mentioned earlier, anosognosia.
Yes, anosognosia. This is a profound lack of insight or awareness of one's own illness. It's not denial, it's a neurological symptom, part of the illness itself for many people with schizophrenia. And it's a major challenge for treatment adherence and engagement.
That must make things incredibly difficult for the person and their family. And schizophrenia has phases, right? It's not always acute.
Correct. There's often a prodromal phase with subtle changes before clear symptoms emerge. Then the acute phase with prominent positive symptoms. The stabilization phase where symptoms decrease, often with medication. And the maintenance phase, focusing on recovery and preventing relapse.
It's clear just how complex these conditions are. Let's widen our lens now to some critical societal issues and specific populations, starting with children's mental health. What are some unique resilience factors for kids?
For children, key resilience factors often involve having at least one stable, supportive caregiver relationship, good problem-solving skills, a positive self-image, and support from school and community also make a huge difference.
And two common diagnoses in childhood are ADHD and autism spectrum disorder, ASD. What are some key parent teaching points for managing these?
For ADHD, inattention, impulsivity, hyperactivity, key teaching often involves structure and consistency, predictable routines, clear rules and consequences, breaking tasks into smaller steps. For ASD, social communication deficits, restricted interest, repetitive behaviors, teaching might focus on using visual aids, maintaining routines which can be very comforting, teaching social skills explicitly, and focusing on the child's strengths. Structure is key for both.
Okay. Now, trauma and dissociative disorders, trauma's impact can be profound. What are the hallmark symptoms of PTSD, post-traumatic stress disorder?
PTSD symptoms generally fall into four clusters. Intrusion symptoms like flashbacks, nightmares, intrusive memories of the trauma. Avoidance, avoiding reminders of the trauma, people, places, thoughts. Negative alterations in cognitions and mood. Negative beliefs, distorted blame, detachment, inability to feel positive emotions. And marked alterations in arousal and reactivity, like hypervigilance, exaggerated startle response, irritability, sleep disturbance.
That sounds incredibly disruptive. And then there are dissociative disorders like dissociative identity disorder, DID. Our sources describe this as the mind creating alters.
Yes. DID, formerly known as multiple personality disorder, is understood as a complex post-traumatic condition. It's thought to develop usually in response to severe chronic childhood trauma as a way for the mind to cope by compartmentalizing experiences. The alters are distinct identity states that recurrently take control of behavior, often with memory gaps between them. It can seem like different people inhabiting one body. The therapeutic goal isn't to eliminate alters, but usually to foster communication and cooperation among them, aiming for eventual integration if the person desires.
Integration back into one identity. Wow. And when people experience dissociation, feeling disconnected, what can help? Grounding technique.
Absolutely. Grounding techniques are incredibly practical and powerful tools. They help bring someone back to the present moment when they're experiencing things like depersonalization, feeling detached from oneself, or derealization, feeling the world isn't real, or during a flashback.
Like the 5-4-3-2-1 technique.
Exactly. That's a common one. Name 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. It forces your brain to focus on the immediate sensory environment, anchoring you in the here and now. Other techniques involve holding ice, stomping feet, focusing on breathing. Very useful.
That's a great practical tip. Now, somatic symptom and related disorders. This is when the body speaks the mind's distress.
In a way, yes. In somatic symptom disorder, the person has one or more distressing physical symptoms, like pain or fatigue, and excessive thoughts, feelings, or behaviors related to those symptoms, causing significant disruption. The key is the distress and dysfunction related to the symptoms, even if a clear medical cause isn't found.
And how is that different from illness anxiety disorder, what used to be called hypochondriasis?
In illness anxiety disorder, the main issue is preoccupation with having or acquiring a serious illness. They typically have minimal or no actual somatic symptoms. If symptoms are present, they're mild. The core is the fear of illness itself, leading to excessive health-related behaviors, like checking, or avoidance, like doctors.
Okay. And conversion disorder, that sounds quite dramatic stress converting into neurological symptoms.
Yes, functional neurological symptom disorder, or conversion disorder. Here, a person experiences neurological symptoms like paralysis, blindness, seizures, numbness that aren't explained by a neurological disease following some kind of stress or conflict. A curious feature sometimes seen is la belle indifférence.
La belle indifference. Beautiful indifference.
Sort of. It describes a peculiar lack of concern or distress about what seems like a major symptom, like being unable to walk. Not everyone with conversion disorder shows this, but when present, it's striking.
Now, a critical distinction our sources make is between factitious disorder and malingering. Both involve faking illness, but the motivation is different.
Exactly. This is a key takeaway. Both involve consciously producing or faking symptoms. But in factitious disorder, including Munchausen syndrome, or Munchausen by proxy where it's imposed on another, the motivation is internal. The person wants to assume the sick role, to get attention, care, sympathy. There's no obvious external reward.
Okay, wanting to be seen as sick. And malingering.
In malingering, the motivation is purely external. The person fakes or exaggerates symptoms for a tangible secondary gain, like getting money, disability, avoiding work or military service, obtaining drugs, or evading criminal prosecution. It's not considered a mental disorder itself, but rather a condition that may be a focus of clinical attention. Both are conscious deception, but the why is different.
That's a really important distinction. Okay, eating disorders, more than just about food, right?
Absolutely. They are serious mental illnesses with potentially life-threatening physical consequences.
Let's compare anorexia nervosa and bulimia nervosa. Key differences.
Okay. Anorexia nervosa is characterized by restriction of energy intake leading to significantly low body weight, an intense fear of gaining weight or becoming fat, and a disturbance in how one's body weight or shape is experienced.
So, restriction and low weight are key? Physical issues?
Severe ones. Things like bradycardia, slow heart rate, hypotension, electrolyte imbalances, osteoporosis, lanugo, fine downy hair, amenorrhea, loss of periods. It has the highest mortality rate of any psychiatric disorder.
Wow. And bulimia nervosa?
Bulimia involves recurrent episodes of binge eating a large amount of food in a discrete period with a sense of lack of control, followed by recurrent inappropriate compensatory behaviors to prevent weight gain, like self-induced vomiting, laxative misuse, excessive exercise, or fasting.
So the binge purge cycle. And weight.
Crucially, individuals with bulimia are typically at or above normal weight. That's a key differentiator from anorexia. Physical issues often relate to the purging electrolyte imbalances, especially low potassium, which is dangerous for the heart. Dental problems from stomach acid, swollen parotid glands, chipmunk cheeks, and sometimes Russell sign.
Russell sign.
Calluses or scars on the back of the knuckles from repeatedly inducing vomiting.
Got it. And binge eating disorder.
Binge eating disorder involves recurrent binge eating episodes, like in bulimia, but without the regular use of compensatory behaviors, so no purging, excessive exercise, etc. It's associated with significant distress about the binging, and often leads to being overweight or obese, with related health conditions like diabetes and heart disease.
Okay. Quickly touching on sleep-wake disorders. We all know sleep is important, but our sources highlight just how broad the effects of poor sleep are.
They really are. Chronic poor sleep impacts almost everything: impaired immune function, increased risk of mood disorders like depression and anxiety, problems with concentration and memory, increased risk of accidents, and metabolic problems like weight gain and diabetes risk.
So the sleep hygiene is key. What are a few top tips?
Consistency is huge. Go to bed and wake up around the same time every day, even on weekends. Create a relaxing bedtime routine. Make sure your bedroom is dark, quiet, and cool. Limit screen time before bed. The blue light interferes with melatonin. Avoid caffeine and large meals late in the day. Get regular exercise, but maybe not too close to bedtime, say within 3 hours.
Great practical advice. Okay, moving into some really critical societal issues. Impulse control disorders. Our sources highlight a potential progression. ODD, IED, conduct disorder. Can you clarify the distinctions?
Yes, understanding the distinctions is key, especially as they often present in childhood or adolescence. Oppositional defiant disorder, ODD, is characterized by a pattern of anger-irritable mood, argumentative defiant behavior, or vindictiveness, typically directed towards authority figures. It's generally verbal defiance, arguing, blaming others. It's disruptive, but usually less severe than conduct disorder.
Okay, defiant, argumentative. What about intermittent explosive disorder, IED?
IED involves recurrent behavioral outbursts representing a failure to control aggressive impulses. These are sudden, brief episodes of intense, often disproportionate verbal aggression or physical aggression. Crucially, these outbursts are impulsive, not premeditated, and there isn't the ongoing pattern of violating rights seen in conduct disorder. They often feel remorseful afterwards.
So sudden outbursts of rage and conduct disorder, CD.
Conduct disorder is more serious. It involves a persistent pattern of behavior where the basic rights of others or major age-appropriate societal norms or rules are violated. Think aggression towards people and animals, destruction of property, deceitfulness or theft, serious violations of rules like truancy, running away. There's often a lack of remorse or empathy. It's more severe than ODD, and childhood-onset CD can be a precursor to antisocial personality disorder in adulthood.
That progression is a really key insight. Okay, substance use disorders or addiction. What are the core signs someone is struggling?
We touched on some earlier. Generally involves things like intense cravings for the substance, loss of control over use, using more or longer than intended, spending a lot of time obtaining, using, or recovering from the substance, continued use despite clear harm, physical, psychological, social, occupational, neglect of major responsibilities, developing tolerance needing more for the same effect, and experiencing withdrawal symptoms when trying to cut down or stop.
Withdrawal can be really dangerous depending on the substance, right? Like alcohol versus opioids.
Absolutely. Withdrawal syndromes differ. For opioids, like heroin or fentanyl, overdoses typically involves pinpoint pupils, respiratory depression, slowed or stopped breathing,
Right.
unresponsiveness. Withdrawal, while intensely uncomfortable, dope sick, isn't usually life-threatening on its own. Symptoms include muscle aches, sweating, yawning, diarrhea, nausea, vomiting, anxiety.
Okay. Then alcohol.
Alcohol overdose can cause respiratory depression, coma, death. Alcohol withdrawal, however, can be life-threatening. It can range from tremors and anxiety to seizures and delirium tremens, DTs, confusion, hallucinations, severe autonomic instability. Requires medical management.
So screening tools are important. Our sources mention CAGE, CAOL, COWS.
Yes, CAGE is a quick screening tool for alcohol problems. Cut down, annoyed, guilty, eye-opener. CAWA, Clinical Institute Withdrawal Assessment for Alcohol, is used to assess the severity of alcohol withdrawal symptoms and guide treatment. CAWS, Clinical Opiate Withdrawal Scale, does the same for assessing opioid withdrawal severity.
And you mentioned the chemically impaired nurse earlier. What's the core message there?
The core message is recognizing the red flags. Changes in behavior, performance issues, medication discrepancies, understanding the professional and ethical duty to report concerns to protect patient safety, and knowing that help is available. Diversion programs exist in many places to help nurses get treatment and potentially return to practice safely, focusing on rehabilitation.
Okay. Neurocognitive disorders.
Yeah.
Let's revisit the difference between normal aging and dementia. Can you highlight those key distinctions again? Because this causes a lot of worry.
It does. Let's break it down.
Memory.
Normal aging, occasionally forgetting names or appointments, but remembering later. Dementia. Frequent difficulty remembering recent events, conversations, relying heavily on memory aids.
Language.
Normal aging, sometimes struggling to find the right word.
Dementia.
Dementia. Frequent difficulty finding words, substituting words, trouble following conversations.
Judgment.
Normal aging, making a bad decision once in a while. Dementia. Consistently poor judgment, like mishandling money, falling for scams.
Ailey function.
Normal aging. Maybe needing help with complex tasks, like setting up new tech. Dementia. Progressive difficulty managing finances, medications, driving, eventually basic self-care.
Awareness.
Normal aging. Usually aware of and perhaps frustrated by memory lapses. Dementia. Often unaware of or underestimates cognitive deficits. Anosognosia may deny problems.
That's a really clear comparison. Now, you also mentioned delirium before. Remind us of the key takeaway there.
The key takeaway for delirium is that it's an acute and usually reversible cognitive disturbance, and it's considered a medical emergency. Unlike dementia's gradual onset, delirium starts suddenly, hours to days. Its course fluctuates, worse at night often, and the hallmark signs are impaired attention focus and disorganized thinking. It signals an underlying medical problem, infection, medication side effect, metabolic imbalance that needs immediate identification and treatment.
Okay, acute reversible emergency. Got it. Alzheimer's disease, the most common type of dementia. What's happening in the brain?
Alzheimer's is progressive and irreversible. It's characterized by the buildup of amyloid plaques, protein fragments between nerve cells, and neurofibrillary tangles, twisted strands of tau protein inside cells, leading to nerve cell damage and death, particularly in areas crucial for memory and thinking.
And the 4A's are often used to describe the symptoms.
Yes, they're useful shorthand. Amnesia, memory loss, especially recent. Aphasia, language difficulties finding words, understanding. Apraxia, difficulty with motor planning, inability to perform familiar tasks like dressing, despite intact motor function. And agnosia, inability to recognize familiar objects, people, or sounds, despite intact sensory function.
And sometimes people with dementia might make things up to fill memory gaps. Confabulation.
Yes, confabulation. It's the unconscious fabrication of stories or explanations to fill in memory gaps. It's not intentional lying or deception. The person genuinely believes what they're saying. It's a way the brain tries to make sense of a world that's becoming increasingly confusing due to memory loss.
Okay, let's touch briefly on personality disorders, defined as persistent, rigid, inflexible patterns of behavior, often lack insight.
That's right. These patterns deviate markedly from cultural expectations, are pervasive across situations, stable over time, usually starting in adolescence or early adulthood, and lead to distress or impairment. A key feature is often difficulty with interpersonal relationships, and yeah, often a lack of insight. They tend to see problems as being caused by others or the world, not their own patterns. Psychotherapy is generally the treatment of choice.
And they're grouped into clusters. Cluster A,
Cluster A is the odd-eccentric cluster. Paranoid, pervasive distrust and suspiciousness. Schizoid, detachment from social relationships, restricted emotional expression, the classic loner.
got it.
Schizotypal, social deficits plus cognitive perceptual distortions and eccentric behavior, magical thinking, odd belief speech.
Cluster B, dramatic emotional.
Cluster B is the dramatic, emotional, erratic cluster. Antisocial, disregard for and violation of the rights of others, deceitfulness, impulsivity, lack of remorse. Borderline, BPD, instability in relationships, self-image, and affect. Marked impulsivity, frantic efforts to avoid abandonment, splitting, seeing people as all good or all bad. Histrionic, excessive emotionality and attention-seeking. Narcissistic, grandiosity, need for admiration, lack of empathy, often fragile self-esteem underneath.
You mentioned the high suicide risk in BPD earlier, 70% attempt rate, 10% mortality. That's stark.
It really underscores the intensity of the suffering in BPD.
And finally, cluster C, anxious, fearful.
Cluster C is the anxious, fearful cluster. Avoidant, social inhibition, feelings of inadequacy, hypersensitivity to negative evaluation. They want closeness but fear rejection. Dependent, pervasive need to be taken care of, leading to submissive, clinging behavior and fears of separation. Obsessive compulsive personality disorder, OCPD, preoccupation with orderliness, perfectionism, and control at the expense of flexibility, openness, efficiency, rigid, stubborn. And importantly, OCPD is not the same as OCD.
Right. OCPD is about pervasive personality traits. OCD is about specific obsessions and compulsions. Good distinction. Now, let's return to the incredibly important topic of suicide. What are some key risk factors we should be aware of?
There are many, often interacting. Major ones include pre-existing psychiatric illnesses, especially depression, bipolar disorder, substance use disorder, schizophrenia, borderline personality disorder, biological factors like low serotonin levels, family history of suicide, previous suicide attempts, a very strong predictor, history of trauma or abuse, significant losses, relationship, job, financial, chronic physical illness or pain, and access to lethal means. Social isolation is also a big one.
And the crucial communication advice you gave earlier, don't avoid the topic. Asking directly does not increase risk.
Absolutely critical. Ask directly, calmly, non-judgmentally. Are you thinking about hurting yourself? Or are you having thoughts of suicide? Express empathy. That sounds incredibly difficult. Avoid false reassurance. Don't worry, things will get better. Listen without judgment. And strongly encourage help-seeking, normalizing it.
You mentioned dispelling myths earlier, too. Remind us of those. Asking increases risk.
False. Asking shows you care and can open the door to help.
Suicidal people hide intentions.
Mostly false. Most people give verbal or behavioral clues, though they might be subtle.
Males more likely to attempt.
False. As we said, females are more likely to attempt suicide, but males are more likely to die by suicide, often due to using more lethal methods.
And speaking of methods, how is the lethality of suicide plans evaluated?
Lethality refers to how quickly and likely a chosen method is to result in death. High lethality methods include firearms, gunshot, jumping from a height, hanging. Moderate lethality might include overdose with certain pills, cutting wrists, depending on severity. Lower lethality might include superficial scratching, taking a few non-lethal pills. Assessing the specificity, lethality, and availability of the plan, along with intent, is crucial for determining immediate risk.
And in a care setting, specific safety precautions are taken.
Yes, absolutely. Depending on risk level, things like removal of potentially harmful objects, belts, shoelaces, sharps, using plastic utensils, ensuring no private rooms, sometimes requiring constant observation, checking belongings, using jump-proof and hang-proof fixtures in bathrooms. Safety is paramount.
Okay, shifting to violence, abuse, and assault. A really sobering point from our sources. The single best predictor of future violence is.
Past history of violence. It's consistently the strongest predictor across many studies. Not the only factor, of course, but a critical one in risk assessment.
And when faced with potential aggression, those de-escalation techniques are key. Calm demeanor, space, listening.
Yes. Remain calm, speak softly, don't be provocative, maintain personal space, don't block exits, use active listening, validate their feelings, I can see you're really upset. Offer choices or options when possible. Set clear, firm, non-threatening limits on behavior. And always ensure your own safety. Have backup available if possible.
Now, mandated reporting. This is a legal requirement for certain professionals, like nurses.
Yes. Mandated reporting laws require specific professionals, varying slightly by state, but usually includes healthcare workers, teachers, social workers, to report suspected abuse or neglect of vulnerable populations, typically children, the elderly, and adults with disabilities to the appropriate authorities, like Child Protective Services or Adult Protective Services.
And the threshold is suspicion. You don't need proof. Our sources mention Georgia law requires reporting within 24 hours.
Correct. The legal standard is generally reasonable suspicion. You don't have to prove abuse occurred. You report if you suspect it might be happening. And yes, timeframes like 24 hours are common. Failing to report can have legal consequences for the mandated reporter.
There was an interesting nuance mentioned for intimate partner violence, IPV, in Georgia. Generally not mandated reporting unless specific circumstances apply.
That's a complex area that varies significantly by state. In many places, including Georgia as noted in the sources, reporting IPV involving competent adults is not mandated unless specific criteria are met, perhaps if the victim is incompetent, under 17 or over 65, or if a deadly weapon was used. The rationale often involves respecting the autonomy of the adult victim, who may fear retaliation if a report is made without their consent. It's a delicate balance.
And a shocking statistic about child abuse perpetrators.
Yes, the sources noted that the vast majority of child abuse perpetrators, something like 92%, are the child's own parents. It underscores that abuse often happens within the family structure.
Okay. Sexual assault. What are some key points here? Dispelling myths.
Key myths to dispel. Rape is primarily about aggression, power, and control, not sexual desire. It absolutely can occur within a marriage or relationship. Victims' responses vary widely. Some fight, some freeze, some appear calm. There's no single correct way to react to trauma. What someone wore or whether they were drinking is irrelevant. Blame always lies with the perpetrator.
And for nurses or healthcare providers encountering a survivor, self-assessment first.
Crucial first step. Before even entering the room, the RN needs to assess their own feelings, biases, and readiness to provide non-judgmental supportive care. Survivors are incredibly vulnerable, and the provider's attitude is critical.
And in the emergency care setting, preserving evidence is vital, like advising against showering.
Yes. For forensic evidence collection, if the survivor consents to an exam, it's vital they don't shower, bathe, douche, brush teeth, or change clothes before the examination. Evidence can be lost easily. The priority is always the survivor's immediate medical and emotional needs, but evidence collection is important for potential legal proceedings.
And date rape drugs. GHB, Rohypnol, ketamine. What are the effects and dangers?
These drugs are dangerous because they can incapacitate someone quickly, often causing sedation, muscle relaxation, confusion, and amnesia. The person may have little or no memory of what happened.
So they might not even know they were assaulted.
Exactly. Dangers include respiratory depression, slowed breathing, loss of consciousness, seizures, coma, and even death, especially when mixed with alcohol. Key safety messages include never leaving drinks unattended, not accepting drinks from strangers, going out with trusted friends, buddy system, and watching out for each other.
That's vital information. Now, a topic that's often hidden, human trafficking. How do our sources define it?
The core definition is the use of force, fraud, or coercion to compel a person to perform commercial sex acts or labor against their will.
And it doesn't require crossing borders. Age doesn't matter.
Correct on both. It can happen anywhere, within a single town or city. And while minors are particularly vulnerable, adults are trafficked too. If force, fraud, or coercion is used, it's trafficking regardless of age or location.
Our sources highlighted a specific nuance in Georgia law regarding child sex trafficking.
Yes, a critical point. In Georgia, a child under 18 is considered a victim of sex trafficking if they receive anything of value, food, money, drugs, shelter, etc., in exchange for a commercial sex act. Importantly, for children, the law presumes they cannot consent, so proof of force, fraud, or coercion is not required. Receiving anything of value for sex trafficking for a minor in GA.
That's a crucial distinction. How are victims typically recruited?
Recruitment methods are varied and manipulative. It can be family members, friends, romantic partners, sometimes called the Romeo pimp, or strangers. They often use false promises of jobs, education, or a better life. Social media is increasingly used. They target vulnerabilities, poverty, homelessness, history of abuse, substance use, being a runaway or in foster care. Common locations for trafficking include hotels, truck stops, online platforms, but also seemingly legitimate businesses.
And the average age of entry is horrifyingly young, 12 to 14.
That's what the sources indicate tragically. It highlights the extreme vulnerability of young adolescents.
And traffickers use a manipulative grooming process. Can you walk us through those steps?
Yes, grooming is a deliberate predatory process. It typically involves 1. Targeting and trust building. Identifying a vulnerable person and gaining their trust, often showering them with attention, gifts, affection, making them feel special. 2. Isolation. Gradually isolating the victim from their support systems, family, friends, school, making the trafficker the center of their world. 3. Abuse and control. Introducing abuse, emotional, physical, sexual, alongside continued affection, creating confusion. Establishing control through rules, threats, manipulation. 4. Maintaining control. Using threats against the victim or their family, debt bondage, exploiting addiction, and psychological manipulation to keep the victim trapped. Often, a complex trauma bond develops.
A trauma bond, like Stockholm Syndrome.
Similar concept, it's a powerful emotional attachment the victim develops to their abuser due to the cycle of abuse and intermittent positive reinforcement. They may feel dependent on or even protective of the trafficker, making it incredibly hard to leave.
What are some warning signs that someone might be a victim of trafficking? Behavioral signs.
Behaviorally, being accompanied by someone older or controlling who speaks for them, answers hesitantly or seems coached, appears fearful, anxious, withdrawn, avoids eye contact, maybe showing signs of unusual sexual behavior for their age, or having stories that don't quite add up.
Physical or health signs.
Delayed medical care, signs of physical abuse, bruises, burns, marks, branding, malnutrition, exhaustion, multiple STDs or pregnancies, poor dental hygiene,
Possessions or appearance.
having large amounts of cash but few personal possessions, multiple hotel keys or cell phones, wearing clothing inappropriate for the weather or situation, appearing much younger or older than their stated age,
Contextual signs.
history of running away, homelessness, being closely monitored or guarded, not being allowed to speak freely, lack of identifying documents, inconsistencies in their story about where they live or go to school.
If someone suspects trafficking, what should they do? In healthcare. Outside.
In a healthcare setting, the protocol is usually to notify a supervisor, social services, or a designated trafficking response team discreetly. Avoid confronting the suspected trafficker directly, as this can endanger the victim. Outside of healthcare, the advice is generally to call law enforcement immediately or the National Human Trafficking Hotline. Don't try to intervene directly yourself.
Okay, thank you. That's incredibly important information. In our final chapter now, let's turn to dying, death, and grieving, a universal experience. Kubler-Ross's 5 stages of grief, denial, anger, bargaining, depression, acceptance are well known, but what's the key insight about them?
The absolute key insight, often missed, is that it is a non-linear process. People don't move neatly from stage 1 to stage 5. They might bounce between stages, revisit them, experience several at once, or skip some entirely. It's a framework for understanding common reactions, not a rigid pathway.
Nonlinear, that's important. And you mentioned distinguishing grief from clinical depression earlier. Can you contrast those again?
Sure. While both involve intense sadness, grief often comes in waves, interspersed with periods of relief or even positive memories and joy. It generally decreases in intensity over time. Self-esteem usually remains intact. With clinical depression, the mood is more persistently low, pleasure is often lost entirely, anhedonia. It may worsen without treatment, and feelings of worthlessness or self-loathing are common. Grief is a natural response to loss. Depression is an illness.
Okay. And that surprising yet profound fact about physical changes in dying from our sources.
Yes. Last to go is the hearing. So talk. Even when someone appears unconscious or unresponsive near the end of life, hearing is thought to be the last sense to fade. So keep talking to them, reassure them, share memories, say goodbye. Your voice can still provide comfort.
That's such a powerful, tender insight. So communication is key, right to the very end. Key tips for communicating with grieving individuals.
Be present. Acknowledge their pain. This must be so hard. Use active listening. Offer practical help, meals, childcare, rather than just saying, let me know if you need anything. Importantly, avoid cliches. They're in a better place, be strong, and definitely avoid giving advice unless asked. Just listen without judgment.
And for communicating with someone who is dying.
Use a soft, calm tone. Ask open-ended questions if they're able to talk. What are you thinking about? Listen more than you talk. Offer reassurance, physical touch, if appropriate and welcomed, words of comfort. Respect their wishes and decisions. Sometimes, just sitting silently, therapeutic presence is the most powerful communication.
That really underscores the vital nursing tip our sources mentioned. Listening without fixing is key.
Absolutely. It applies in so many of these situations we've discussed.
Finally, let's briefly touch on older adults. Perceptions of aging vary culturally.
They really do. Some cultures revere elders for their wisdom and experience, while others, unfortunately, harbor more negative stereotypes, ageism. These perceptions impact how older adults are treated and how they see themselves.
And our sources mention transinstitutionalization. What is that? It sounds like a systemic issue.
It is. Transinstitutionalization refers to the phenomenon where, following the deinstitutionalization movement closing large state psychiatric hospitals, many individuals with serious mental illness didn't receive adequate community support. As a result, they ended up moving from psychiatric hospitals into other institutions, primarily jails, prisons, nursing homes, or becoming homeless. It highlights the failures of underfunded community mental health services, lack of affordable housing, social stigma, and the criminalization of mental illness.
That really sheds light on a major system failure. So the nurse's role includes challenging ageism.
Definitely. Challenging stereotypes like assuming older adults are forgetful, incapable, or uninterested in life. Advocating for their dignity, autonomy, and right to appropriate care. Recognizing that mental health issues are not a normal part of aging.
And communication tips for older adults. Avoid patronizing language.
Yes. Use therapeutic, respectful, non-patronizing language. Speak clearly, maybe a bit slower. But don't shout unless they have a known hearing impairment. Give them time to respond. Acknowledge their feelings. Avoid dismissive phrases, "you'll be fine." Elder speak, using overly familiar terms like honey or dearie, or forced positivity.
And the SPICES framework helps assess common issues.
Yes, SPICES is a useful acronym for assessing potential geriatric syndromes or common problems in older adults. Sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, skin breakdown. It prompts a quick check for these key areas.
So after this incredible journey, what does this all mean? We've covered so much ground, from the very foundations of mental health and brain chemistry to complex disorders, care systems, and huge societal challenges. It feels like you, our listeners, now have a much richer framework, right? Key insights, actionable knowledge.
I hope so. I think what we've really seen is that mental well-being is this dynamic continuum. It's constantly influenced by our biology, our experiences, our environment. And understanding the nuances, whether it's the subtle signs of lithium toxicity, the specific definition of child trafficking in a particular place, or the difference between grief and depression. It just empowers you. It allows you to approach these topics with hopefully greater empathy, more awareness, and really informed critical thinking.
Yeah, this deep dive really reveals that true understanding. It isn't about having all the answers, is it? It's more about knowing the right questions to ask.
Exactly.
Recognizing the complexities, seeing the profound interconnectedness of our physical and mental health in ways we often just gloss over.
Absolutely. So for you, our dedicated learner, maybe here's a final thought to ponder. In a world just flooded with information about mental health, some good, some not so good, how will you use this deeper understanding you've gained today? How will you move beyond just consuming knowledge to truly connect, observe carefully, and maybe contribute, even in small ways, to a more informed and compassionate society?
That's a powerful question. Keep diving deeper, everyone. Stay curious. And thanks for joining us on The Deep Dive.